I'm going to introduce our next speaker for the topic, lung cancer screening. So Bernadine O'Leary's 30-year nursing career has been dedicated to cancer care, and she has practiced in all aspects of the cancer care trajectory. She has been certified in oncology nursing since 1996. Bernadine is treasurer of the Newfoundland chapter of the Canadian Nurses Association of Nurses in Oncology and is a member of CANO's National Education Committee. She is also a professional associate with Memorial University of Newfoundland's Faculty of Nursing. Welcome, Bernadine.
Thank you, Barbara, and thank you, everybody. Can you hear me okay and see my screen?
Yes and yes.
Okay, thank you. So this morning, I will quickly review the burden of lung cancer, review some evidence that supports lung cancer screening, do an environmental scan of where we are in Canada now with regard to programmatic lung screening. We will review lung screening program design and pathways, the role of navigators, the very important role of navigators within a lung screening program, and discuss some engagement strategies for lung screening. So to begin, let's look at the impact of lung cancer. And this slide shows you the past 40 years and the trend for lung cancer. The dark blue line represents lung cancer in men in the country, and the red line represents lung cancer incidence with females. The shading represents the past 5 years. And we notice for the most part that for men, the incidence has gone down. And in recent years, it seems to have plateaued. And that's a direct response to tobacco cessation programs, which came on in earnest late 70s, early 80s. So I guess the good news, if there's any such thing, is that the incidence rate for men have lowered nationally, and they seem to have plateaued. Unfortunately, the most recent estimates with regard to lung cancer incidence for women is that we have now equaled men in terms of the number of cases and new incidents. So in the mid-1980s, the difference between lung cancer in men and women, it was 60% men and 40% women, and now we are 50-50. So the good news is, the rates are down. The rates have plateaued. There has been some success with our tobacco cessation programs, but unfortunately, the bad news is lung cancer mortality. Okay, so the incidence of lung cancer is now less than breast, prostate, and colorectal cancers. However, it has and continues to have the highest mortality rates and the poorest patient outcomes. And one of the reasons for this we'll look at a bit later is that lung cancer currently, when it's diagnosed, unfortunately, it is at its later stages or its higher stages, advanced stage 3, stage 4 disease. And this significant mortality and diagnosis at late stage lends support to the value of a lung screening program. Now, this slide looks a little busy, and I don't want to overwhelm you with it, but it gives us the age distribution for cancers and the age at which individuals are diagnosed. So, again, the most common cancers, breast, prostate, colorectal, and lung. And what we notice is that the higher incidence of diagnosis occurs in the later aspects of life. So for males and females, for lung cancer, the majority of cases are diagnosed in the 70s. Second highest occurs in the 60s, and thirdly in the 80s. So as people age, the risk for these cancers and lung cancer increases. So this helps us to identify the target for lung cancer screening. Coupled with this, the demographic estimates for Canada. By the year 2030, when most of you who are students will be out in your practice, the estimated population of Canada in 2030 is estimated to be just over 9 million people. 25% or a quarter of that population will be 60 years of age or above. So the demands and the challenges on our healthcare system is clear. So the need for programmatic population screening programs to help us identify diseases earlier is very important. So where are we now in lung screening in Canada? So the province of British Columbia and the province of Ontario, their lung screening programs are up and running. Alberta has a pilot project that completed in Q2 of this year, and we're awaiting their final results. Quebec has their lung screening pilot, which they refer to their lung screening project. Nova Scotia has actually began some lung screening. They have started a phased-in approach. They are lung screening in their central region of their province with a vision to roll out to other provinces as well. Saskatchewan, Manitoba, and you there in New Brunswick are in some phase of planning and discussing the feasibility of implementing a lung screening program. In Newfoundland and Labrador, we're starting to discuss our pilot project, and with our pilot, hope to be screening before year's end. It needs to be noted that the development, the planning, and the implementation of lung screening programs in Canada has been generously supported by the federal government, their cancer control strategy, of which the Canadian Partnership Against Cancer is the governance body for that strategy. So the evidence to support lung cancer screening globally, the past 10 to 15 years, numerous randomized control trials have been documented. And I won't be detailing these for you today. The references are available. The most common or the most popular ones, the Dutch-Belgian lung trial, the Danish lung screening trial, and the National Lung Screening Trial in the US. In our Canadian sources and our Canadian references, it's the US, the Danish, and the Dutch, which we tend to reference more. So in a nutshell, what the evidence suggested for us is that without lung screening program, and getting back to my earlier slide about mortality rates, without lung screening program, 57% of people diagnosed with lung cancer will be stage 4 disease at the time of diagnosis. And with stage 4 disease comes complex multimodal treatments, symptom management issues such as pain, loss of appetite, weakness, end-of-life care, and supportive care costs. What the randomized controlled trials from around the world showed us was that with programmatic lung screening, 77% of lung cancers diagnosed through screening are diagnosed at stage 1, 77%. And with stage 1 disease, There are less costs to the healthcare system in terms of management, better outcomes for the participant, and better quality of life, and less demands on end of life and supportive care needs. So what does a lung screening program? Common lung screening program actually have two components. The screen test, which is an actual low dose CT scan coupled with a tobacco cessation program. And what we're learning is that the most important arm of a lung screening program is the tobacco cessation program, because all those entered into a lung screening program are actually not eligible to receive the low dose CT scan. So this is a common lung screening care pathway. An individual is referred to the lung screening program. They may be referred by the healthcare provider. They may self-refer themselves, or through a community organization, maybe someone like NB Lung or a tobacco cessation program. The eligibility will tend to be based only on the amount smoked. When the client enters the lung screening program, a screening navigator with the program does what's called a detailed risk assessment. This detailed risk assessment determines if a screen test is required. The screening navigator will also do a very detailed tobacco use assessment, and 100% of participants who identify as smokers or recently quit will be navigated to the tobacco cessation arm. We want to set that up as an opt-out option, meaning we want to navigate everybody into tobacco cessation and support them with that. And if they don't want it, well, then they can opt out themselves rather than setting it up as a choice. So again, the options for eligibility, we will take referrals from family doctors, walk-in clinics, and public health. And we will also receive referrals from the emergency departments and specialty care. This is the setup for our pilot. If we progress to a provincial lung screening program, we hope to get into self-referrals and referrals from community health organizations and a public website option. So these are sample eligibility forms from Ontario and BC, just some client information. The eligibility criteria for the provider is clearly outlined. The common age is 55 to 74, currently smoking or have smoked in the past and have a smoking history for 20 years. Conversely, we're also outlining what the ineligibility criteria is. So if they currently have a lung cancer, under surveillance for other lung nodules, and certain jurisdictions will disclude or exclude individuals who have COPD and other lung diseases. So once they enter our lung screening program, the screening navigator does this detailed risk assessment with the client. So we do a deeper dive into the tobacco smoking use, duration, intensity, how much they have smoked, and the number of attempts they have had to quit in the past, what worked and what didn't work. We will look at body mass index, some socioeconomic factors, which are very important when dealing with lung cancer participants, a personal cancer history, the personal history of lung diseases, a family history of lung cancer, and ethnicity. Based on this risk assessment, the programmatic screening programs have what we call risk calculators, okay, which are the probability or the risk of that individual upon this risk assessment developing a lung cancer within the next 5 to 6 years. In Ontario, they're using a 2% calculation or greater, but for our uses in Newfoundland and Labrador, we've opted for the 1.5% or greater risk based on this assessment of developing lung cancer. For those who meet this criteria, they will be navigated to the CT scan, the low-dose CT scan test. For those who fall outside of this criteria, they will be navigated to our tobacco cessation arm. So for those that are eligible for the screen test, it is a low-dose CT. If it is negative, the participant will be notified as well as their primary care provider, and we may CT scan them again in another 2 years. If it is a positive or an abnormal scan, we will then move on to a diagnostic follow-up, which exists now in most acute care areas. That will be additional imaging with another CT, MRI, particularly of the head, if there is presence of disease outside the lung, or a PET scan. Some may also go to an invasive procedure or a biopsy, such as a CT-guided biopsy or endobronchial ultrasound biopsy. So depending upon the pathology results and the results of these tests, the participant will go back into the routine screening arm or be referred to appropriate management, be it respirology or oncology if it is a cancer. So the important role of navigators within lung screening. For Newfoundland and Labrador, our navigators are registered nurses, but they are social workers, pharmacists, respirologists in other jurisdictions. So monitoring the eligibility, the important risk assessment and risk calculation, the tobacco cessation referral, and supporting these clients with education and support. I should also let you know that within our tobacco cessation arm, pharmacotherapy support for tobacco cessation will be supported for a period of about 3 months, free of charge to our participants. They do the education around the screen test and the prep and the safety checklist prior to the CT. They will do communication of results, most especially abnormal results, which require further testing. They do the coordination and the management of the care pathways so that additional testing or biopsy occurs in a timely manner and that the participant is available for it. Symptom assessment, management, supportive care, and required referrals, particularly when lung screening identifies a participant as having a lung cancer. And the lung screening navigators are the primary contact for the program, be it for participants, the public, and healthcare professionals who require assistance. Engagement and promotion is extremely important. For a lung cancer program to be successful, we must target the most at-risk individuals. So what we are at now is identifying and engaging with key stakeholders in our planning, medical imaging, primary care, and leaders and community supports within Indigenous populations and those of lower socioeconomic standing. We will also couple our engagement strategies that have worked in population screening for our breast, cervical, and colon screening programs. So these are my references should you wish to take a deeper dive. Thank you so much for your time and attention. And Barbara, if there is an opportunity for questions, I'll leave it to you as monitor. If not, feel free to email me or write me a question in the chat separately, and I will, in the interest of time, answer it for you. Thank you so much.
Thank you, Bernadine. We have been trying a little 5-minute sign. Did you happen to see it? We're trying it for the first time.
I saw you put a thumbs up. Yes.
Oh, okay. We have a little sign that we're trying this year that
I didn't see a sign. I saw you though, but thank you.
Yeah, so we have a couple of minutes. So there is a question in the Q&A. So we do have a couple of minutes.
Okay, thank you. Okay, cute. How is, say, smoking cessation support provided for patients? Is it done at point of care, or is the patient referred to a provincial quit line? In terms of our pilot program, the screening program will provide it to the patients. We have a central pharmacy in our largest hospital that will mail out the support. Our biggest question now with regard to our pilot as to who will be the prescriptive authority. We would like to get a nurse practitioner. However, human resources hasn't allowed for that. We can work with clinical pharmacists, and we can also work with medical directors for the prescriptive authority. So it will not be done at point of care, because most of our point of care and most of the support for tobacco cessation we expect to be virtual, and with a mail out of the pharmacotherapy support. What are the lifestyle changes that can reduce or slow down the development of lung cancer aside from not smoking? So aside from not smoking, the lifestyle changes, we recommend the healthy diet, according to Canada's food guide. We recommend maintaining a healthy weight. We recommend moderate activity as per Participation in Health Canada, 150 minutes of moderate activity a week, or 30 minutes 5 times per week. I think that has the prognosis decreased from what your experience has seen? Actually, no, our prognosis has not decreased from my experience. Our pilot is not up and running yet, but we are appreciating an increase in referrals to our diagnostic arm. So the number of lung cancer incidents is actually climbing here in Newfoundland and Labrador. Unfortunately, we haven't witnessed that decrease in incidence here yet.